So hello Leslie.
Hello.
And my name is Annalise, and what I'd like to do today is examine your respiratory system. What that will involve is I'd like to have a look at your hands, I'll be looking at your face, and I'll ask you to undress, and I'll be having a look both at the front and the back of your chest. Are you happy with that?
Yes.
Note also symmetry of the chest movement. You want to see whether the chest is moving symmetrically and that it's moving as it should be. So I'm going to start off in front of the ears. These glands are called pre-auricular glands. Using a gentle rolling motion with my fingertips, I'm just feeling to see whether there are any raised nodes at all. The basis of this technique is to place your non-dominant hand on the patient's body surface, and with your dominant hand to strike your first or second finger at the distal knuckle to help produce a sound or a note. Hello, my name is Annalise Woods and I'm a senior lecturer at Canterbury Christ Church University in the southeast of England. I teach on a number of modules at the university, both masters and degree level, that focus on advanced health assessment skills. Today we're going to be looking at examination of the respiratory system, and I will focus on key skills and techniques that you need to learn. Your approach to this examination should include preparing the patient, examination of the hands, the face, the thorax, and looking at the skills of palpation, percussion and auscultation. It's very important that you prepare your patient and your environment appropriately. So preferably you want a nice, warm, private environment. Your patient should be examined on a couch or possibly on a chair. And it's important that you examine both the anterior and the posterior chest, preferably examining the full anterior before the full posterior chest, or vice versa. It doesn't really matter which way that you start. This helps to prevent the patient getting fatigued from moving backwards and forwards during the examination. You should explain to your patient what this procedure involves and make sure you've got their consent. So hello Leslie.
Hello.
And my name is Annalise, and what I'd like to do today is examine your respiratory system. What that will involve is I'd like to have a look at your hands, I'll be looking at your face, and I'll ask you to undress, and I'll be having a look both at the front and the back of your chest. Are you happy with that?
Yes.
That'd be great. What I'd like to do now then is I'm going to go and wash my hands, and I'd ask you perhaps to remove your top, and then we'll get on with the examination.
Okay.
Thank you. Okay, let's begin. You should start off by doing a global overview of your patient. This is important to check that it's appropriate to begin with the examination and that there's nothing that immediate needs to be done. So have a look at your patient's consciousness level. Have a look to see if they're in any sort of distress. In this case, we're looking for respiratory distress. Can you hear any wheezing, any stridor? Our patient seems to be nice and comfortable, so we're going to continue with the examination without any other interventions. I'm going to start off by having a look at the hands. There are various features on the hands that you can have a look for. I'm going to start off by looking for capillary refill, testing for peripheral cyanosis. Press firmly on a finger, release, and you should see the finger colour return to normal within 2 seconds, which it does on this patient. Next, have a look at the palms. In patients that are retaining carbon dioxide, have hypercapnia, they may have very red and very sweaty palms. Again, this is not the case in this patient. You should inspect the nails. You may see nicotine staining if your patient is a smoker, but you're also looking for clubbing, which is present in chronic respiratory conditions. If you ask the patient to put 2 fingers together, Leslie, if you could put your 2 fingernails together, what you're looking for, and you may be able to see that or you may not, is a small diamond between the nail beds. That would indicate clubbing is not present. Thank you very much. I'm now going to move up to looking at the patient's face. I'm looking to see whether there's any obvious signs of anemia. That might be a patient who's very pale, and I can look at the eyes. Could I just ask you to move your glasses for a moment? If you could look up for me, if you just gently pull down the eyes, you're looking at the mucous membranes to make sure that they're nice and pink. Thank you. Do observe for respiratory distress. Patients that have respiratory distress might demonstrate nasal flaring or pursed lip breathing, where they're holding their lips together and the respiratory effort is increased. We're also going to have a look at the neck, because we can see in the neck signs of respiratory distress also. Patients may use their accessory muscles in an effort to improve their breathing. So we need to look for that, which we see no evidence of that in this patient. It's also important to examine the trachea. What you can do is, if you find the sternal notch just between the two clavicles, and gently placing 2 fingers, gentle pressure backwards. Let's see, it's just going to feel a little bit uncomfortable. Thank you very much. You're just assessing whether or not the trachea is midline, which it should be. The trachea can be deviated in conditions like pleural effusion or a pneumothorax. As part of the examination of the neck, you should be examining the lymph nodes. This is because very often in respiratory pathology, with upper respiratory or lower respiratory tract infections, patients might have raised lymph nodes. In addition, they can have raised lymph nodes when they have tumours in the chest, such as in lung cancer. So we're going to be doing examination of the lymph nodes, and I find it easier to examine from behind because the main purpose is actually to feel the lymph nodes rather than to look at what you're doing. However, you may see techniques in other books or in other areas of clinical practice where people examine from the front. So I'm going to start off in front of the ears. These glands are called pre-auricular glands. Using a gentle rolling motion with my fingertips, I'm just feeling to see whether there are any raised nodes at all. Then I go behind the ears to the post-auricular, and then I'm just going to be feeling right at the base of the skull for the occipital nodes. Coming back to the jaw, I'm dropping down to the tonsillar nodes. See if I can feel anything there, and then I'm running along the jawline, submandibular, submental nodes. Can't feel anything raised there at the moment. Coming back to the tonsillar, I'm now going to look at the anterior cervical chain. So this is the chain of nodes that run down the front of the neck. So again, using this rolling motion, feel whether there are any raised lumps. If you feel something, stop, examine a bit further, try and map out what you can actually feel. But keep going down till you get to the clavicles. Then going along the top of the clavicles, keep pressing, and it's really, really important that you actually look for glands here. These are the glands that might be raised if a patient had a tumour in their lung, and they're called the supraclavicular glands. And then finally, come back up the posterior cervical chain. So that's the chain of lymph nodes that run up the back of the neck till you reach the skull. Okay, so let's move on with examination of the anterior chest. We're going to start off with inspection. The first thing to look at and observe is the patient's breathing pattern. Note the rate, rhythm, depth and effort of breathing. When looking at the chest, signs of respiratory distress can be evident visually with intercostal recession or subcostal recession. And this is where the effort of breathing is such that these areas are sucked in as the patient is breathing. Also look at the chest shape. It's important to work out whether the chest looks normal or whether perhaps the patient has a barrel chest, which you often see in patients with COPD. The way to do this is to have a look at the anterior, the front, to posterior to lateral ratio. So what we're looking at is that the patients should have a ratio of 1 to 2. The chest should be half as thick as it is wide. This would be a normal chest. In someone with a barrel chest, we find that that anterior posterior ratio has increased, and we've got a 1 to 1 ratio. So that's quite important. Also look at the sternum. Sometimes some respiratory conditions will cause changes to the sternum and deformities of the sternum, which might impact on breathing. Note also symmetry of the chest movement. You want to see whether the chest is moving symmetrically and that it's moving as it should be. Okay, we're going to move now on to palpation. 2 things we're looking for when we're palpating. One, we're palpating the chest for tenderness. That may be as a result of trauma. For example, if the patient experienced a fractured rib or a fall. And we're also going to be feeling for tactile fremitus. So let's start with palpation for tenderness first. Placing your hands on the patient's chest, just press gently, watching the patient's face, looking for any grimacing, and asking the patient if they feel any pain at all. Any problems? No, that's great, thank you. For tactile fremitus, this is a technique whereby vocal transmissions from the pulmonary tree are expressed through to the chest wall. And you can normally feel those at the base of your fingers or the side of your hand. It's very sensitive to vibration. So I'll demonstrate how to do this technique. If you put your hand on the chest, you can either do it this way, as I said, or the bases of your fingers, and ask the patient to say 99.
99.
And again, please.
99.
And one more time there.
99.
And then just one at the sides.
99.
That's great. What you will feel is a slight vibration in your hands. Now, tactile fremitus is palpable in the normal chest as long as the person's got quite a strong voice. If you've got someone who's very weak with a soft voice, you may find it difficult to feel. In addition, if the chest is very large, if a patient's got a lot of muscle mass or fat on their chest, then you may not be able to feel that fremitus. It's also diminished in some conditions, for example, patients with a pneumothorax where there's a lot of air in the way, or in patients with pleural effusion when there's a lot of fluid in the way. Equally, it can be increased in some areas, and this typically occurs in a patient with pneumonia where there's a patch of consolidation, and when you are feeling over the area of consolidation, the tactile fremitus is increased. Okay, so let's move on with percussion. Percussion is a technique that people often find quite difficult to master, but with practice, it's something that you should be able to do. The basis of this technique is to place your non-dominant hand on the patient's body surface, and with your dominant hand to strike your first or second finger at the distal knuckle to help produce a sound or a note. And that should give you the note that you're looking for. It's important to have a soft wrist. If you use a very rigid wrist, you'll find it very difficult to elicit a note. So percussion is very useful in the respiratory examination because it tells us what's underneath the area we are percussing. For example, normal air-filled lung tissue should have a deeply resonant note, and that's the sound you can hear now. If you go over a solid area, so something like the heart, then you would expect to have a dull note. And you can hear how different that is. Okay, let's look at where we actually percuss then on the chest. It's really important that you use a systematic approach and that you cover the whole of the lung fields. It's quite helpful, therefore, to try and visualise the anatomy underlying the chest. For example, the lung apices actually protrude above the clavicles, so you must start your percussion above the clavicles. And you should always compare side to side. So let's have a go. We're getting a nice resonant percussion note. And you can see that I'm going each side of the sternum. We've gone dull over the heart again. Now I've gone down each side of the chest. I'm now going to do the lung bases. So we're going to go into the armpit, always comparing side to side. Okay, so we've used a very systematic approach. 4 areas either side of the sternum, starting above the clavicles, going down over the chest, and then 2 areas underneath the arms to get the bases of the lungs. So as I explained earlier, we were expecting to hear a nice resonant note over those lung fields. When you have certain problems in the chest, certain pathologies, that note will change. For example, if a patient had a pleural effusion and there was a collection of fluid, that would come across as very dull. In fact, that note is often called stony dullness. Likewise, the patient that perhaps has a consolidation due to a pneumonia, that area where the pneumonia is will become very dull on percussion. Conversely, if a patient has a lot of air in their lungs, so perhaps they've got a pneumothorax, that will come across as hyperresonant. So it sounds a bit more of a booming sound rather than a deeply resonant sound. Sometimes patients that have COPD, that have hyperinflated chests, will also have this slightly booming sound when you try and do a percussion note on them. So, for percussion, it's really important that you use a systematic approach and that you recognise the different notes and understand what those mean. The final stage of examination of the anterior chest is auscultation. So you need to be able to use your stethoscope. The principle for this approach is very similar to percussion. In order to cover the lung fields, you need to start above the clavicles and you need to be comparing side to side. In a moment, I'm going to be talking to you about the different respiratory sounds that you can hear, but I want to first of all show you the technique. It is important that you listen for a full inspiration and a full expiration in each location. So I'm going to demonstrate that on the patient just now. Leslie, what I'd like you to do is just to relax your arms by your side, please, and breathe a little bit deeper than normal through your mouth, okay? And just breathe away as you feel comfortable. And if you could lift your arms up slightly, I'm just going to go into your armpit slightly. That's great. Thank you. And you can now breathe normally. I just want to talk to you now about some of the normal and abnormal respiratory sounds you can hear on auscultation. There are three main types of normal breath sounds. One is called vesicular, one is called bronchial, and the other tracheal. Now, vesicular breath sounds are heard all over the lung fields, and they're characterised by you being able to hear the full inspiration and only 1/3 of expiration. So it kind of sounds like this. It's a soft, quiet sound. Bronchial breathing, however, is heard mostly over the main bronchi, so you'll hear it over the sternum and maybe the first and second intercostal spaces. And that is a much slightly harsher sound, and that's characterised by you being able to hear full inspiration and full expiration. So it sounds a bit more like this. And finally, tracheal breath sounds. These are the harshest and loudest sounds that you hear, and they are heard mainly in the neck over the main trachea. And they're characterised by a louder, harsher sound of full inspiration, a gap, and then full expiration. So it sounds a bit like this. So those are your normal breath sounds that you'll hear as you are examining the chest. Now, bronchial breath sounds can be abnormal if they are heard anywhere in the chest other than where we said they were normal. We said they were normal over your main bronchi. So if you were to hear bronchial breath sounds down in the bases of the lungs, that would suggest that the patient has an abnormality, and often it's associated with things like consolidation and pneumonia. Let's move on to adventitious or abnormal breath sounds now, and there are quite a few of them, some of which I'm sure you'll be familiar. For example, wheezes are quite common. These are common in patients with asthma and in heart failure also. These are high-pitched sort of musical notes that often are heard throughout the chest during inspiration or expiration. Now, wheezes may be polyphonic or monophonic. Polyphonic means that they are heard throughout the chest, so that's what you'd expect in asthma, whereas a monophonic wheeze tends to be heard in one localised area. That suggests that perhaps one particular airway is obstructed, perhaps due to a foreign body or due to a tumour. Other abnormal sounds can be rhonchi. Rhonchi are a deep snoring quality sound that you hear when you're auscultating, and typically that represents secretions in the upper airways. Very often when a patient has this, if you ask them to have a good cough, then that will clear, and that suggests it was rhonchi. Rhonchi is common in any condition where you have a lot of sputum, so things like COPD or perhaps an infection. Other abnormalities can be things like a pleural rub. This occurs when, in conditions like pleurisy, when the two pleura become roughened and inflamed, and with each breath they rub together and they cause a sort of creaking, grating sound, which is often associated with pain for the patient. And patients can often localise it and say it's kind of here that it hurts. Other abnormal respiratory sounds are crackles. They're sometimes known as rails. They can occur in inspiration or expiration, and they may be fine or coarse. They occur in things like pneumonia and also in heart failure. Sometimes you can reproduce the sound of crackles. If you get a piece of hair and you rub it next to your ear, it sounds a little bit like what you'd expect when you hear crackles. And finally, stridor is another abnormal respiratory sound. Now, stridor you can often hear without using a stethoscope. This is an inspiratory sound and is a result of the upper airways, usually trachea or main bronchi, being obstructed, and is usually associated with acute respiratory distress and requires immediate attention. I'm now going to demonstrate examination of the posterior chest, which essentially is going to be a repetition of everything we did on the anterior chest. What I'm going to do is do it quite fluidly so you can see how the examination goes through as it progresses, and I will talk through what I'm doing as I go through. Starting off then with inspection. Have a look at the shape of the chest. We've already ascertained that we have a normal shaped chest, but have a look at the spine. Some spinal deformities can impact on patients' breathing. Note also the symmetry of the chest and whether there's any evidence of respiratory distress. We're now going to move on to palpation, and we're going to start off to see whether there are any tender areas. Leslie, could you tell me if there's any tender areas, please, as I'm pressing?
No tender areas.
Okay. While I'm here, I'm actually going to have a look at how Leslie's chest moves, looking at respiratory expansion. What I'm going to do is place my hands on his rib cage and my thumbs around his spine, and I'm going to say, Leslie, could you take a deep breath in, please? And out. Okay, we're going to just try that one more time. Breathing in and out. What you can see is that my fingers are being dragged by his ribs as he's breathing in, and what I'm looking for is a symmetrical movement of my hands, which there was in this case. That suggests that his chest is moving symmetrically. Okay, I'm now going to move on to tactile fremitus. If you could say 99 for me, please.
99.
And again.
99.
And again.
99.
And one more time.
99.
Thank you very much. We now move on to percussion, remembering to start high up to cover the full lung fields and to compare side to side. You'll notice that I did 5 areas, each side of the spine, as I went down the chest, and 2 areas in the lung bases at the side of his chest. Finally, we're going to move on to auscultation. So once again, we're going to use our stethoscope. And Leslie, if you could take deep breaths, please, in and out of your mouth for me. Thank you, and if you could breathe normally. So that concludes the respiratory examination. I hope you found the demonstration useful. There are many textbooks that outline how to do this, and some of those are listed at the end of this presentation. Thank you very much for joining me.